Good morning, everyone. So, I'm presenting a case which is beyond the obvious. It's a great imitator as an advanced ovarian cancer. She's a 40-year-old female and she presented with abdominal pain, distension, and dyspnea. Ultrasonography showed 13 centimeter solid mass in the right ovary with moderate ascites, and serum CA125 was moderately elevated, with ascitic fluid showing few atypical cells. X-ray chest showed mild pleural effusion, and thus a provisional diagnosis of advanced ovarian carcinoma, which deemed inoperable, was made. So a core needle biopsy was done, which showed spindle cell neoplasm, and based upon the biopsy finding, a total abdominal hysterectomy with bilateral salpingo-oophorectomy was planned. Post-operatively, ascitic and pleural effusion resolved completely, and CA125 level returned to the normal. So this is a gross picture. You can see that this is a big ovary of 13 centimeter, and this is a uterus cut open with the cervix and endomyome. Now, this is a cut surface of this ovary showing solid gray white areas. And based on this cut surface and this gross appearance, the differential diagnosis of Brenner's tumor, carcinoid, and Brukenberg's was made. So the microscopic picture on the low part showed sheets of spindloid cysts, which on high part showed that the chromatin is bland. And thus a differential diagnosis of fibroma, thecoma, solitary fibrous tumor, or sclerosing stromal tumor was made. The IC showed negativity for the calretinin, CD34, Ki67, also for S100, ER, CD10, and desmin. Thus, it rules out the differentials that is thecoma and solitary fibrous tumor. So, final diagnosis of fibroma ovary with ascites and pleural fluid, that is a Meek syndrome, was made. So this is a rare condition which accounts only for the 1% of the ovarian tumors, and histopathological examination is crucial for its accurate diagnosis. The prognosis is excellent, and as the treatment is just a surgical removal of the tumor, which also resolves ascites and pleural effusion. So the impact of misdiagnosis is that it increases the risk of unnecessary palliative management and it delays in the curative surgery. So the conclusion is that histopathology confirms the essential accurate diagnosis, and this is the impact of ISC and biopsy. You can see in this case that the advanced inoperable malignant tumor, which was a clinical diagnosis, was converted to a benign tumor on the final diagnosis after biopsy and ISC. Thus, there is no need of the PET-CT, costly genetic test. There is no need of the radical surgery, no need of chemotherapy, hormonal therapy. There are no chances of recurrence. The intent of treatment has changed from palliation to curative. There is no anxiety or stress to the patient, and she live a better quality of life. So the take-home message is not every mass is a monster. Biopsy helps us to differentiate them. And the biopsy teaches that not treating blindly is also a treatment. Thank you.